Hello, everyone, and welcome. My name is Sam Bass. I'm with the Market Intelligence team here at Open Minds. And today, as part of our weekly Circle Elite Roundtable series, we have Hackensack Meridian Health Carrier Clinic President Don Parker and Open Minds Senior Associate Jason Littman. And they will be discussing the social determinants of health and the next normal. And they'll be talking about partnerships, collaborations, and leveraging resources. Now, due to technical difficulties from the storm, while you can't see Don today, he has called in, and so he'll be here. And now to introduce the speakers, Jason Littman brings over 15 years of executive experience in health and human service field to Open Minds with expertise in healthcare strategy, public policy, government relations, managed care, and communications. And prior to joining the Carrier Clinic in 2013, Don Parker served as Vice President for Physician Services and Ambulatory Care at St. Joseph's Health System. And previously, Parker was appointed as President and CEO of Atlantic Mental Health for 15 years and subsequently merged into Atlanticare Health System. Now, before we start, we have a couple of brief housekeeping reminders. First, while you are muted during today's briefing, we're open to any questions that you may have. Please feel free to submit those in the question box, and Jason and Don will have time at the end to answer them. And secondly, as a reminder, the recording and PowerPoint from today's briefing will be available tomorrow on the Open Minds website. And without further ado, I leave you with Jason and Don.
All right, thank you, Sam, for that introduction. Welcome, Don. Glad you're able to join us, at least by phone. Sorry we can't see you in person, but that's fine.
Thank you, Jason. It's better that you don't see us because we've been working overnight here at Carrier since we had a touchdown of a tornado on the campus and had to close the hospital down and work through the evening. So,
well, thank you for still being able to make this. It all ties into social determinants of health too, because these disasters are shining a spotlight on how they affect different populations.
Indeed.
All right, so here is a brief overview of what we're going to talk about. First, we're going to go over a social determinants of health strategy, and then we'll focusing on developing strategic partnerships and collaborations, which is key to the social determinants of health strategy, since no one could actually do it on their own, especially because of all the sectors it involves. And then in the final section, before we get to the Q&A, we're going to talk about creating a comprehensive care model that also addresses the social determinants of health. So this quote I had found by Plato in the Republic says, "Our need will be the real creator." I came to this when I was Googling how necessity is the mother of all invention, and there wasn't someone who was responsible for that quote, but I found a source that said it evolved over time back from here. So social determinant of health needs is going to be driving, the models we put in place, or at least we hope it will. So here's an overview of social determinants of health from how the World Health Organization defines it. It's all the non-medical factors that influence health outcomes. It could be where you live, where you work, where you play, where you were born, and how you grow and develop. And they influence health equity in either positive or negative ways. And in many ways, they have more influence on health than the direct physical health incidence itself. So there's a list here of all different things that can affect it. And I don't even think there is a comprehensive list, because the more I read about it, you can keep finding more and more social determinants of health. But obviously, income is a big thing. Having resources can get you more health access, or in the opposite, you could limit your health access. And social protections, programs and services that are the safety net that keep people from falling into poverty or going out of poverty. Another one is education, starting from early education through high school and even higher education. It affects what options you have as we get to. It could be employment options or the type of health benefits you get and access. Obviously, unemployment would be a big barrier to health and health care. But even if you have a job, your job could limit your flexibility, especially on days like today, where there's a natural disaster and, people may have trouble with childcare issues and have to work as well. Or as we saw in COVID, many people were able to work at home, but many were not because they have public facing roles or they're essential workers. Work-life conditions is basically what I touched on. Food insecurity is also a big thing because nutrition, there's an expression, nutrition is medicine. So it's not even just about whether you're experiencing hunger, but also the types of food that are in your neighborhood, whether it's a food desert that doesn't have access to healthy foods, or it's an area that's just full of unhealthy food. Housing is a very big thing. There's the term housing is healthcare. When you think about it, without stable housing in place, it's really hard to focus on your health. You're more worried about where am I going to live, where will I sleep, where will I find food. And healthcare can't be your top priority when you have to meet basic needs. Early childhood development, I touched on with education. Then the social inclusion, non-discrimination touches on, racism, social justice, which could affect people's access to resources, opportunity, and healthcare. Structural conflict is here probably because it's the World Health Organization, and if you're in countries where groups are competing for resources or there's violence, that would obviously have an effect too. And then access to affordable healthcare and services in decent quality. Don, I know you don't have these slides in front of you, but I know you're following along with the version I sent you. Is there anything you want to add here, or we can move on and then start the conversation?
No, we can move on. I'm going to give you a perspective on this, a little historical perspective, as soon as the right opening happens.
Sure. So moving on to slide number 6, which has the circles around the person in the middle, which simplifies a little bit some of the major factors that could affect a person's health. It crosses sectors, and this illustration is just showing that, having the person in the center of all these determinants that I spoke about before influences them. And when we get to planning, you want to keep the person at the center of the planning. And also from the World Health Organization, they noted that it could count for 30 to 55% of health outcomes. I've also seen other literature and studies that even have it higher. So it definitely is a major factor. And you have to change your perspective on how you may look at physical elements, because you need to get back to the root causes that might be causing the physical illness. These outside sectors all drive health outcomes. So solutions require actions from all these sectors working together. You can't just focus on one. You have to look at the entire picture. And that's where working with multiple organizations and having these close partnerships comes into play to having an effective strategy. So moving on to slide 7, Don, this is just illuminating how the COVID pandemic shined a spotlight on social determinant of health factors. Depending on where someone lived and how their housing was or their type of job, they had a different exposure risk to COVID-19. One, if you didn't have stable housing or were living in a congregate facility, or even in such as a homeless shelter or in prison, there was a larger exposure just because of the density of people living in one space. So overcrowded housing is an issue. And then, as I touched on before with your occupational position, there just are some professions where you're going to be coming in contact with more people because you have to. Think about like during the pandemic when they talk about, grocery workers. Grocery stores had to stay open so people could have food. But if you're working there, you're exposed to everybody who's coming in. So that was an increased risk. And some things that played into this that happened while we were all sheltering in place during the pandemic is that the highest number of overdose deaths occurred in 2020. And some of this had to do with, people weren't able to get the services they were getting if they couldn't go to them if the clinic wasn't opened. And also there were isolation issues, people at homes, self-medicating because we weren't living in a normal environment where staying at home could cause depression. And if you have, risk for addiction, that could be a trigger for it. And another thing, unfortunately, that happened in 2020 is that life expectancy fell for the first time, I think, since World War II by 1.5 years across the population. But when you break it down, you see it was even higher for other groups. 2.9% decline for African Americans, a 3-year drop for Hispanics, and even higher for Hispanic males. And then there were also, which you see in the media, you know, there were more homicides occurring. And CDC has also confirmed higher death rates from physical illnesses like diabetes and chronic liver diseases, which plays into people being able to access their health care based on their living situation, whether they were able to go to clinics or even have the ability to access virtual care, which was another disparity amongst people. So Don, I'm going to move on to slide 8 now. This is the model. So I wanted to credit, and Don recommended I read this book before the presentation. I almost got through the whole thing, but I've been reading through it pretty quickly. It has a lot of good information. If you really want to dive deeper into the social determinants of mental health, this is a recommended book. And they have this model which works on different levels. It has a multi-level perspective to show all the driving forces. And the greatest impact for population health, which we'll get to later, is whether you can change public policies and social norms, because that is where you could hit upstream that has an effect on people's health programs and social conditions as we go up to these different levels. Don, do you want to add anything on this slide before I go through?
You can see the complexity of mental health determinants. And frankly, you know, if you go through most of the social determinant lists, you don't have mental health among them. Mental health is an outcome of social determinant issues, just like health is an outcome. And so I think it's important to understand that when you're setting up your strategy.
Right. And when I mentioned that the level of public policy and social norms has this big upstream effect, depending on our policies and our social norms, it affects things like, if you see the next level, the distribution of opportunity among different groups and different people who have power or more economic wealth. And then above that, you see it starts listing how opportunity determines the next level of social determinants, where you see housing and education there, where, you know, depending on, you know, where you stand in life, you would have different options and different effects from these determinants. And then as you come around, you know, they take into account, you know, health policy and the health system and how that determines access to care, and poor access will not equal good health outcomes. And on the other side, environment then touches the genetic component. So the genetic component is still there, but the environmental factors can trigger whether genetic risks occur or don't sometimes. So I'm going to move on from this framework. We'll break it down to a little bit easier. I know when you first look at it, it looks really complex, but it's a complex issue. There are a lot of things happening at once. So this pyramid gets to, when you're looking at strategies, if you want to really impact social determinants of health, the bottom of the pyramid has the most population impact. So on an individual level, counsel and education can really help people, but if you want to get to the population, you go back to these social economic factors that set the context for, you know, what decisions people will make and where they will live and where they will work and how they will access healthcare. And then there's just different interventions as you go up and down, you know, the population and the individual. It's theoretical, but I think it's good to look at when you're trying to solve population and individual cases. So I'm going to move on to the next slide. So Don, here's something where I think you'll have good insight, the strategies for social determinants of health in the next normal, because I know you've been involved with a lot of collaborations and partnerships on this issue, which is listed first because it's a really big thing. And then there's things you could do as a provider to beef up capacity listed on here or look at different options.
Jason, on this area, it's kind of interesting because my career has been woven around the social determinant strategy from a very early time. I actually did my first merger. I was president of a mental health center 1986. And in 1994, New Jersey was working its way into a managed Medicaid project. And management was different than social determinants, but it had some of the elements in it. And so I decided that we needed to have a full continuum of care, which you're going to see as we continue through our slides. And that full continuum of care was kind of impossible for me to get from the perspective of being a mental health center. I didn't have the inpatient capability. I didn't have high access to psychiatry. I think that remains a problem for mental health centers today. And so I created a merger. I did a presentation for Open Minds 2 years ago on why, when, and how do you go through the options of merger as a way of creating a more relevant business model for your mental health center or whatever component of the mental health system you represent. And so from that point, I began, as I joined a health system, I began to look at behavioral health as a component of a larger system, and that behavioral health, if we did interventions in different health issues, we could make a big difference. I became in 1996, so a couple years after the merger, I got appointed as the Vice President of Business Development for the system. And I had that role until 2003. I developed so many businesses that were adjacent to both mental health and healthcare that they appointed me as president of what was called Atlanticare Health Services, which had 21 different businesses, 42 locations in South Jersey. And we began competition for something called the Malcolm Baldrige Award, which is a presidential award for the highest quality health system in the United States. And there are several sectors of that award. The award is given to you by the president. It's fierce competition. There were over 300 hospitals that were seeking to attain this award. In 2006, I had the unusual experience of meeting who actually is now considered the father of this strategy, of the social determinant strategy, of the value-based healthcare strategy. Michael Porter is a professor at Harvard. I went to a seminar with a team of my colleagues at Atlanticare looking at differentiating our system. We had a health plan, so I in a Forrest Gump way was in the right place at the right time to learn about running a health plan. I ran the behavioral health component of a health plan that we started to ensure the casinos in Atlantic City, which was our major business area in South Jersey. And we were building a very strong network, ultimately insured 12 of the 13 casinos. And during the time that we insured them, we developed an incredibly broad social determinant strategy. This is back close to 17 years ago that we started the work. And there were no footprints in the sand at that time. There were no books to read. Michael Porter had just begun his work. He had actually published a book called Redefining Healthcare, Creating Value-Based Competition on Results. And so he was introducing some factors into healthcare that just didn't exist prior to this time. That lecture really stimulated our team. We began to take on the challenge of creating a social determinant network. We started with daycare centers, interestingly enough, and developed a series of daycare centers that created what we felt was interaction with young kids, where we could teach the kids through our curriculum and through our education and their families about getting good health services. We did that in very, very high demand networks in neighborhoods that were very low income neighborhoods that had a high utilization of charity care in an interest of being able to manage the ultimate consumption of charity care in our marketplaces. So I've got multiple different examples of that as we'll go through the remainder of this discussion about how you can leverage this social determinant strategy in a variety of different ways.
Right, good, because that's a good segue into the next section where we'll get into the how-to with the strategic partnerships and collaborations. And yes, there's many different options outside of merger acquisition. There's getting into a network or being able to make referrals and many more. So we're going to move ahead. So some things we're going to talk about and look at as we go through strategic partnerships and collaborations is, especially for now, we want to gauge the next normal landscape. And a lot of people are saying, well, how are we going to do that? Because there's a lot of uncertainty now. But because there's uncertainty, it's even more reason to try to assess what's out there and look at your options and be ready, to pivot it if necessary. In a social determinant strategy and looking to create, these partnerships, you want to look at the community and the populations around in the catchment area that you serve, consumers, consumer preferences, providers, their expertise, what they can offer, health plan priorities, which we're also going to get into because health plans are really getting active in this area. They're looking for partnerships where they can address the social determinants of health and where providers can show their value to the health plan to meeting goals and priorities that payers and health plans are looking for. And technological capacity is a big part of this because you need to have the infrastructure in place, the data capacity, the ability to evaluate and communicate data. And that's another area where partnerships play into this. And then with engaging, the stakeholders, you want to get upstream. And I think Don has a lot of insights of, how do we get to the upstream? And another question people have is, well, how am I going to pay for this? And, through these partnerships and value propositions, it can open up, other revenue streams or diversify funding. This sounds a little repetitive. Collaboration across the sectors and systems is key, and I already covered the data and outcomes measurement. So these next slides will give you an assessment of the themes happening now. Just to give credit, if you were at MBPI last week and saw Monica's closing remarks, I lifted these next 3 slides from that presentation. But what she went over in there as the driving forces is how the rate of disability in the US, whether you're looking at it by age, obesity, or because of diets, and I want to throw in here, you should also look at social determinant of health factors that's driving a lot of the programs and policies. Health plans are coming in. They're looking for integrated solutions to this. If you follow the news on health plans, there's new models coming out for social determinants of health. There's new collaborations and partnerships and acquisitions amongst health plans. So it's very dynamic. Consumers also want integrated care. If you could go to one place for your behavioral, your medical, and your social needs, it makes things a lot easier and it breaks down a barrier to access. The backward integration where the health plans are also providing services, becoming payviders, is a phenomenon that's happening. And tech and digital, especially after the COVID pandemic, we've all moved to more ways, not only to communicate digitally, but also to track health, to monitor health, to access care online. There's a lot of money pouring in from private equity and venture capital. So there's a lot of innovation happening. And this is another force that's out there. I always think to the transitions that I was involved in as far as policy, there's been government reform, there's been managed care that's been moved to value-based payment, and now you have this other behemoth of billions of dollars coming in from private companies, which is also going to be a big player and influence the market. the next one,
Hey, Jace, that's
yes,
just the pure scope of that. 300 new apps for your technology for behavioral health in 2020, and $3 billion worth of investment. That was double the investment in 19, and we expect that to increase by at least another 40% in 21. So you're looking at rushing money into the behavioral health world because of opportunity.
So it brings about competition, but it could also open up opportunities if people could partner with that. It would definitely open up revenue and try to influence where that money goes.
You know what I have done in that area is that for the last almost 10 years, I have a monthly time period set aside in my calendar where anybody who contacts me with a new product, whether it's an application or it's BI that will help us get better handle on the type and quality of care that we deliver, and anything related to behavioral health, and you contact me, you get time with me. And I look at the products, I'm able to search through them, I'm able to connect them. I look at my brain developing business models for the use of the products, which, by the way, aren't always fully thought through by the companies who are developing the products. They have the technical capability, they have some wunderkinds working for them that can really change the way we practice mental health, but they don't necessarily have the knowledge about where in the behavioral health field can you actually both use those products and sell those products so that you can make enough to sustain the effort. And so that's where I see my level of expertise. And frankly, not a lot of people doing that kind of thinking. They get kind of overwhelmed with the product capabilities or the pure number of products and an analysis of where, when, and how to use it is an effective communication, and also opens doors to investment. Our health system invests in new product development. We have a whole arm called Discovery and Innovation Center, and so I will frequently recommend investment from our own technology funds in products that would be of benefit to us in the behavioral health world.
So it sounds like a whole other topic for another webinar, this area.
I think it is. I think the intersection between, it's interesting in our profession, we did not get money when every other health system in America got money as a part of the Affordable Care Act to implement an electronic medical record. That put us further behind the 8 ball, and from a technology point of view. And so we're still catching up on that. Many of us, if we have electronic health records, have limited records that don't necessarily have the level of interactivity across the continuum of care. I'm converting to Epic right now, which is 62% of the market share in technology. That conversion, I'm coming from Meditech, and Meditech is a very solid electronic medical record, and I would say it's probably in the middle to the head of the pack for smaller organizations. Epic, which I could not have afforded if I wasn't part of a health system, will put me into a almost universal access system for exchange of information on our patients, and then us providing information to other providers about how we're treating patients. So it really is a key to collaboration.
So last on this slide, relevant to social determinants, Medicaid and Medicare are quickly adopting digital health as well. So that opens up even more opportunities and more ways to help people get connected to care and services. We could probably, because of time, go quickly through these next slides because they kind of do overlap, but we just wanted to drive home these themes of what's happening in the next normal. Don, I'm on slide 14.
Yep.
Obviously, we talked about integrated care, but building on digital, There's the emerging of the hybrid model where you could do a mix of telehealth, face-to-face, even in home. A lot of services are moving into the home environment to provide, better care, better outcomes, and reduce costs where people don't have to be staying in the hospital or an inpatient facility. So that's another thing to evaluate, the hybrid models. Next bullet just talks about some of the areas that are going home. Long-term addiction treatment, nursing home facilities. We talked about the new competition, the payviders, and it's all affecting the prices and costs and reimbursement models where value-based payments come into play for at-risk models. Next slide just sums it up more about all the business model opportunities that are there when trying to provide integrated whole person care that treats all the complex needs of people, and leveraging the technologies and how risk-based, value-based purchasing can help move these things along and provide the incentives for it. The emergence of primary care services needed for complex needs, so they have a regular place to go to stay connected and healthy and track their health, and a place where they could be referred to the other areas. Home-based service we spoke about. Social supports are being targeted. We will touch on that in the next slide about health plans looking at social supports and how you could partner and contract with health plans and the in lieu of services that are happening amongst these types of contracts in replace of the more expensive inpatient and residential care. So the way you position yourself amongst these themes will and show your outcomes and performance will make you more valuable to the payers and allow you to serve populations in different ways. So this just provides some examples of health plans going into the social service sector. You see the first one with WellCare, with grocery delivery attached to medical services, United Health looking at housing. Like, these are things you might not have heard of definitely over a decade ago. I know in 2011 I was working on an MRT affordable housing program in New York, so it was alive then. Humana looking at value-based programs that address SDOH, and then WellCare offering different grants for local social services and relief programs for COVID-19. Don, I think a question that people might have when looking at this is how do you contract with health plans, or at least get involved to help guide the development of these programs?
Yeah, so in my current situation, being part of a 17 hospital health system I merged into almost 3 years ago, one of the things that attracted me to the system was their intention to enter the insurance business. Last year, we launched a managed Medicare program in partnership with Horizon Blue Cross Blue Shield and one other health system. It's since expanded to a third health system. We're the principal owner along with Blue Cross Blue Shield. But what has happened now is that we have created bundles of care throughout our health system using our inpatient, outpatient, and emergency care capability to manage patients through episodes of behavioral health. And we added, for instance, last year, actually 2 years ago, behavioral health urgent care. We thought every hospital out there, those of you that are running crisis units in hospitals, know that they're extremely difficult to operate. They are not customer friendly, so they don't help your customer service scores. Is incredibly expensive for everybody, and they're not terribly effective. They generally determine whether you're a danger to yourself or others, and if you're not, you're treated and treated. The behavioral health urgent care that we developed mimics the urgent care visit, so that we didn't diminish the type or quality of care that a patient gets in the emergency department. So they actually come to an urgent care center that happens to have a behavioral health component to it. They're cleared physically, which is what happens to you in an emergency department. You're then moved, if you're physically okay, you're going over to the urgent care behavioral health side, and then you are seen by a social worker, which is how your visit starts in an emergency room in New Jersey. You have to be seen by a certified screener. We do the same. And then we have nurse practitioners and also use our telepsych hub to service patients. We have a telepsych hub, which is personed every day by a number of psychiatrists and nurse practitioners who have expertise in a variety of different areas, which we can access if our nurse practitioners find a more complex case than they may feel capable handling, or they need special expertise, whether it's child or geriatric. They can bring in our hub with those experts on it. So we priced it at well below half of what an insurance company would pay, or a patient would pay for that matter, so that it is financially much, much less expensive. It is really a bell ringer for customer experience. Patients like it. We're quick. We also connect them with services after their visit, which the emergency rooms have a tough time doing. And then we are working on an additional component to it that we call euphemistically the Apple Store of behavioral health, where we're going to vet. We've already begun that process. We actually have developed some ourselves, applications that will assist patients in managing their episode and or their chronic condition, and that we would both vet, educate, select, and educate patients for how to use an app. Those 300 apps are deciding which one to use are awfully confusing for patients. And then in addition to that, we are creating monitoring capabilities so that we can follow our patients instead of a separate organization being created to manage the patients. So we think it'll give us a unique advantage in the market, handling what frankly are almost always started as emergency cases, and that's the work that we do, behavioral health.
Okay, great. I'm gonna move us on to our final section because I definitely want to leave time for questions on this topic. So we'll talk about, promoting the comprehensive care that also addresses SDOH. So things to look at in this area, you want to know the population needs and do a scan of the populations in your service catchment area and geographic. We're going to talk about, predictive analytics that determine, someone's social determinants of health, how they're affecting them, how they're affecting their health status. Other things that play into here is the cultural and societal factors. We'll eventually look into what program and policy inventions we could do on a micro and a macro level, and the different types, of collaborative care models that are there. And, just re-emphasizing the need for having, data and being able to measure performance to ensure quality, and how digital, and having telehealth options is a strategic tool as we go forward into the next normal. So Don, a lot of these next slides I adapted from some of the models that you did at Hackensack to develop your SDOH strategy. So I'd like to talk about, how you first, I'm on slide number 19, how you started, the strategy or overview.
Just let me step back for just a second, because I want to comment on your previous slide of
I'm going to go back to
promoting comprehensive care that addresses SDOH. So the difference between me being a freestanding psychiatric hospital, we're a large hospital at Carrier Clinic. We have over 300 psychiatric beds. We're the largest inpatient provider in New Jersey, private, not-for-profit provider. And we're one of the larger in the country. So we should, based on our both size and financial position to be able to handle equipping ourselves for the future. I found us frequently coming up short, and when I talk to my colleagues in the field, they're all experiencing the same thing. Getting money to invest in the necessary equipment, technology, people, in order to come up with a effective strategy is very, very challenging when you don't generally develop a large margin and don't have the ability, other than to meet your immediate needs, to invest in new things. So being part of a health system, I immediately picked up a BI system that has predictive analytic capability. We have literally hundreds of thousands of people that we treat on an annual basis on our health system, and we have 38,000 employees. We all contribute to the EPIC system, and that EPIC system has a variety of different analytic capabilities, as well as giving us constant data on shifting issues in health in the areas that we serve. We are able to stratify cultural and societal factors in that analytic process. We can narrow it down to precincts, to neighborhoods, and then we can specialize the care that we give, especially if there's a scarcity of a particular service, into an area where we can make the greatest intervention. We also can create services in 18 different campuses, plus we have over 500 ambulatory locations. If we need to outpost something in an area, we have immediate capability generally in those outpatient locations to provide care. We are currently in over 60 primary care practices. We have collaborative care where we have social workers are stationed full-time into the pediatric practices so we can catch issues early. Our psych hub serves that now. We have almost 90% of our visits. We have over 2,000 outpatient visits a week. We're doing 92% of them by telepsychiatry, makes us more efficient. We get higher show rates. We believe we're getting higher compliance, and we're studying that right now. We have a couple of research projects going on. I have the ability, being a system of that magnitude and size, I run all the behavioral health across all the 18 hospitals, and we can go out and create relationships very quickly. It's a great interest to organizations to participate with us because we can provide referrals at a very large scale for needed services. And then the quality and performance improvement, we are what's called a high reliability organization. Our staff are all getting specialized training as part of the whole systems initiative in what's called HRO, and it's a very specialized and very successful way used by the military to create quality assurance, especially in the Air Force. And you saw it in the making in this recent airlift out of Afghanistan. So we believe on all 7 of those areas that are on page 18, we bring capability to the table specifically because of the relationship that we are in and the size and scope that we have, as well as resources to fund the necessary transitions.
So I think what you started to say, I think you brought up like the major barriers that organizations would feel right now if they wanted to get into this area, which is having the infrastructure and having the financing. And you have a very successful model in place, but also want to emphasize that is also one way to do it. There's many ways for people to get connected to different networks and healthcare networks outside of being connected to a hospital. So I think that's something that might come up with people too.
I think this is the 3rd merger that I've been involved in, but I can tell you in between all those, I started my work with Hackensack Meridian in a collaborative arrangement, helping them to develop a substance abuse treatment program in a market they weren't used to. We did the assessment. We are building the facilities, overseeing that. We started that work well in advance of the merger. When I get interested in recommending a merger to our board, each 3 times, I specifically reached out to systems that we thought would have a compatible culture to ours, and I asked to work for the organizations for a year in projects like we took on with Hackensack Meridian, so I can go back and report to the board, this is the culture that we've worked on, this is a compatible culture. Culture is the most important thing and the most important match. It's great to have all the resources, but if you have a culture you can't work in, it's going to fall flat on its face.
Right.
And so each of those 3 times that I recommended it, I tested it, we got the right partnership, and it produced on the page 19, it produced for us a base for the social determinant strategy, an existing multi-million consumer community that we could draw off of, attributed lives in our own health plan as well as all the health plans. I immediately was contracted with health plans that I couldn't get contracted with because of the nature and scope of the relationships that Hackensack Meridian had that I couldn't develop, and that insurance companies weren't interested in dealing with single organizations. They liked the aggregated resources that a health system provides. The variety of geographic populations. As a mental health center, I was always looking to balance my paying business, insured business, with my uninsured business in order to be able to keep the doors open. And I have a very strong balance now, and most hospitals have strong balances in it. And if not, they're eligible for charity care and other types of reimbursements that are difficult to secure if you're an individual practicing behavioral health organization. And then I'm able to draw on the best and the brightest of behavioral health workers because of the sheer size and multiple locations that we offer throughout the state. Our 38,000 people, close to 2,000 of them are behavioral health providers. We have residency programs. Right now, we've expanded our psychiatric residency to 60 residents. We have 14 fellowships, 14 fellows now in our fellowship programs with 4 different fellowships. We are providing education for the medical school that's owned by the health system for all of their students, so we interest them in psychiatry. It gives us a supply of practitioners, which, by the way, is often vexing for the smaller organizations, because if you lose a practitioner, you don't have enough wherewithal to replace them quickly, and you don't have enough to get the kind of quality that you want, because if a psychiatrist has a choice between teaching and practicing versus just practicing, many psychiatrists are drawn to the teaching opportunity. So having a large organization, which is slide number 19, really gives you a distinct advantage when you're putting a social determinant strategy together.
And I'm moving forward because I do want to leave time for questions. Slide 20 has the identify, access, and in green. You want to touch on that?
We have, especially through the use of apps and our technology and our information systems, the ability to identify patients who are going through constellations of changes in their lives, either through chronic diseases, through surgery, through stress. We can identify ahead of time using BI whether we have patients who should go through screening, behavioral health screening. And we offer that screening in many different venues and in different circumstances. Our assessment tools are, because of our discovery and innovation division, are evidence-based. We vet them. We do research with them. We're able to bring to the table a level of accuracy that you wouldn't get by just adapting something that's off the shelf. And then our interventions are multifaceted, whether it's a team going out into your community to manage disasters, like we are doing right now. We have some of our psychiatrists doing and practitioners doing mental health first aid for communities that were really damaged by this hurricane. Our staff are involved in providing care for our COVID patients. We manage behavioral health interventions for them, managing building of resilience. Our behavioral health staff are involved in all kinds of initiatives across the system, and those interventions are also offered out to communities.
And then this next slide, 21, just emphasizes the person-centered approach and planning everything around the consumer and having shared decision-making. I don't think there's more we could add to this, Don, correct? I just want to make sure.
You know, this shared decision-making process, the technology, we use a system, I'm not advertising, but just to give you an idea of the system, was called NowPal. And it gives us the ability to match patients with social services systems. It's almost like a match.com for social services. And so we can, based on a profile of our patients that are taken by community health workers in high demand communities and high utilization communities for healthcare, for behavioral health services. And then we match those individuals up with support organizations, whether it's housing or it's food insecurity. You go down that list of social determinant issues. We have organizations and or we provide the service ourselves and or we finance an expansion of the services in a variety of different ways through partnerships, through fund development, through resource sharing. We provide out to mental health centers. We contract with mental health centers to provide their chief medical officers out of our Department of Psychiatry so that we can give them greater quality, greater continuity, and greater capability with their CMOs. That allows us to have a CMO who can interact with the mental health center and customize care and programs for patients that are leaving our inpatient systems or where we want to avoid an inpatient stay. So that matching process and getting the right resources to the right place at the right time are all enabled by our screening process.
Great. And slide 22, just I wanted to emphasize that on average, the life expectancy for people living with severe mental illness is 25 years or less. And a lot of that has to do with preventable diseases that are just, not getting treatment because of the social determinants of health, and because of access to healthcare. And what we want to try to strive for, which mixes into a lot of things that came out of the pandemic, is for everyone to be able to have equal access to healthcare and to behavioral health and social determinants, to make sure that individuals and communities are healthy, especially as we look at what went wrong or what went right with the pandemic, and be prepared for the next pandemic and natural disasters, so we come out of this in a better place.
Jason,
yes,
I think that this is a critical time. It's an inflection point for us in behavioral health to rethink the way we operate and how we operate.
Definitely.
And the small cottage industry that we have grown up in is not going to work in this much more complex technology-driven, resource-driven world that's required in order to handle issues like COVID. The scope, the depth of the issues that it creates, we are ill-equipped to deal with what we expect to be the tsunami of behavioral health services that is now building in our communities. The Spanish flu, the closest pandemic to mimic what we're going through today, suicidality post the eradication of Spanish flu didn't peak until 3 years after the pandemic. So,
yeah, there's definitely going to be a long tail and a long after effects after this with needs. And this last slide just shows, some actions that could be taken. The first one, program interventions, what could be taken, within inside the clinic as far as screening prevention tools and training workers and having guides for the employees and having a referral system in place, even if you don't have this large infrastructure in place, but a place where you could send people. But we covered other areas where you could actually build or partner where people could get the, employment, education, housing, and assistance programs that they need. And on the policy intervention side, I actually come from a policy background in my early career. It never hurts to mobilize and inform elected officials and decision makers about, the programs that you run, the consumers that you serve, what the issues are, and you have the expert knowledge to educate and inform policymakers who are further away from the ground of how these issues affect healthcare. Cross-sector collaborations, once again, is key, and just getting as much people and organizations involved across all the social determinants from housing, education, employment, and so on, is how we will tackle this. Ending with a quote, "Being willing is not enough, we must do." And we're going to go to Q&A. I know we only have a few minutes left, but I definitely do want to hear some questions. And if we don't get to all the questions, we will answer them individually after the webinar. So hello, Sam.
Hey, Jason. Yep, just a reminder for everyone, feel free to submit any questions in the chat box that should be on the right-hand side of your screen, that little pop-out. We have one question to kick us off here. So when addressing some of these issues of social determinants of health when investing in them, some of the initial pushback that I've seen is that it can take sometimes decades to see or a long time to reap the financial benefit from the investments that you're making. One, I guess, is that assumption correct? Are we finding that there are some short-term financial benefits to making these investments? And then two, if it is correct, how do you justify making these social determinant of health investments, knowing that perhaps the patient might be seeing a different physician, or they might move, or how do you justify these things?
Again, this is an area where scale is incredibly important. So thinking about it, the mental health center that I ran back in the 80s, doing the work that I'm doing today, when we have an excess of 2,000 employees working on behavioral health issues, I had 150 at the mental health center. And my ability to invest in a new initiative was dependent upon the state's willingness to give me a grant. Today, I don't have to do that. I can go to insurance companies. In fact, we have multiple ventures with insurance companies around the use of applications. I have a meeting tonight with Horizon Blue Cross Blue Shield around the use of an application in our patients that are being released from the hospital. So, and we have also invested in our own development of applications, and we are close to Princeton University and been working with them around the development of a post-hospitalization that would allow us on deviation from the measurement systems that we're using of 25% to bring you back in for a checkup from the neck up, for a tune-up. And I produce immediate cost savings with issues like that, which would be very challenging for a smaller provider to do. So I think finding scale is very important right away, early in the game, so that you do get sources of funding and you do get the kind of capability you need to make change in health systems and in behavioral health systems.
Great. Jason, do you have anything to add to that?
I mean, I'm thinking short term, like a housing first model would have a short term gain because you're getting somebody housed. I know they especially have supportive housing models that would also connect them to different supports. So that would be an example of a short term gain right there, but that also produces long term.
Gotcha.
But collecting the data to prove the long term to get short term investments could also be helpful.
Okay, great. I think that's takes us to our time for today. Again, if you have any questions later, please feel free to submit them either to me or Jason, and we'll get them answered and get back to you.
And there's one thing I do want to add. Where Open Minds is having an executive leadership retreat the week of September 20th, and I will actually be on site for quick consults if you want to talk more about this topic and how to, create social determinants of health and influence programs and partnerships. So reach out to me. We could do a quick consult if you're planning to attend. So register first.
Perfect. Yes, great plug. And Jason, I think at the very end, there might be one more promotional slide for next week.
Yes. But these are actually more resources that we have on the Open Minds website. And if you read today's daily briefing that went out late last night, it has the links to these as well. If you read Monica's briefing. And this is coming up.
Yep, and please consider joining us next week, September 9th. We're going to have Mina and Jim, but they're going to be talking about exploring options for nonprofit fundraising. It's going to be great. Again, as a quick reminder, the presentation from today and the recording from today will be available tomorrow on the Open Minds website. Dawn and Jason, thank you so much for your time today, despite all of the storms. I hope everyone's staying safe. Thanks for joining us today, everybody, and we'll see you next week.
Thank you, Sam, and thanks for everyone for joining.
Thanks, Jason.
Thanks.